Thank you, Maura, and thank you, Pietro, for the kind introduction. Thanks to Adam and to Harry for continuing to run this meeting and the invitation. So I'm going to talk about insights from intrahepatic analysis, and I'm going to start by acknowledging and thanking Adam for sharing some of the slides with me. But this has been some fun work that we've done and some others have done trying to really dig into what's going on in the liver. So here are my disclosures. And so when we think about why we would look in the liver, there's a number of reasons this can be helpful. And I'm going to try to go through a few examples of each and thinking about, first of all, how we do it. So there's different approaches to sampling the liver, and we'll discuss the pros and cons of core versus FNA, validating or identifying peripheral biomarkers, which I think is an important role. And then I think I'll try to convince you that we've learned a lot about disease pathogenesis and biology from looking at a relatively small number of samples, both on the immunological and virological side, and then how this gets integrated into studying the novel agents, both for thinking about how we choose patients for particular drugs, and then also to help understand the mechanism or mechanisms of action of these novel agents. So first, thinking about the approach, how do we do this? There's pros and cons to FNAs and to core biopsies. And I would really say the FNA has a lot of utility. I think this was started by the Rotterdam group, but it's been taken up by a number of different groups. And I think the advantage here is really minimal risk, minimal pain. And you can see that if you compare the size of the needles down at the bottom, you can see that these are smaller than a bloodletting needle, so really quite a small needle. And surprisingly to us, patients really do tolerate this well, and they allow us to bring them back frequently so you can get serial sampling. And you really do get very high quality immune cell populations, which I'll show you. But the downsides are that you get variable cell yield, both the type of cells and the number of cells, and that's particularly true for hepatocytes and adherent cells that are a bit underrepresented, like macrophages. There is a problem with blood contamination, which can be overcome, but it's still a challenge. And of course, we don't get any histology. On taking a full biopsy, the downside, of course, is that it's invasive with a risk of complications, and that makes patients and providers reluctant to do it. It also makes it costly, and it's really a major limitation on doing it more than once or maybe at the beginning and end of a trial. But the big advantage here is that in addition to looking at the cells, you get histology, architecture, and the spatial orientation of the cells, how they interact with each other. So all the cells are there, and it's really important for some, also for looking at the yield for some of the viral markers like cccDNA. So I'll show you a few examples of how this has been used, starting with how this can be, looking in the liver can be used to validate biomarkers, and I would really highlight the work of the Lyon group. Barbara Testoni and Fabien and Massimo have done a fantastic job really validating some of these things that we think we know what they show, and here are just examples for correlated antigen and HBV RNA, where doing liver biopsies really showed that these are indeed actually showing us transcriptionally active cccDNA, which we sort of thought was the case, but actually having the biopsy data to show that it correlates with intrahepatic cccDNA transcription is really important, and that's true for both of these. And then I think this study showing that you can actually get cccDNA out of an FNA is important also, because it highlights here that you can see here when you take both the antigen positive and negative patients, comparing the yield from a core biopsy to an FNA, and what you see is that in both you see similar measurements of both cccDNA and replicative intermediates, and that importantly they correlate both from the core and the FNA with the HBV DNA in the blood. So that's telling you that you're really getting a pretty good metric of what's happening inside the liver with this relatively small sample in an FNA. And on the flip side, the core biopsy does give you really this spatial view and the whole architecture. And this is a study from Kyung-Mi Chang's group using samples from the Hepatitis B Research Network. And really, in addition to beautiful pictures, the imaging mass cytometry really does allow you to see how the different cells interact. And in this example, I'm using it as an example of highlighting a biomarker because it does actually show the spatial architecture of the liver and the interaction of the cell types. And here, what Kyung-Mi was interested in was comparing e-antigen positive patients, IT to IA patients. Not surprisingly, you see more activation of the immune cell populations in the IA patients, both numbers and activation. But interestingly, that actually correlates, as you can see in the top, with ALT. And so we sort of always say, well, ALT is not a very good marker of immune activation, and we should be cautious about interpreting that. But I think these data actually suggest that at least when you look at it purely in that setting, it's not a terrible marker of immune activation. They also noticed notice that with older age, you get increased Kupffer cell and adaptive immune cell activation. So I think this just gives us a tool to use, and I'll show you that this can be used in other settings. So then looking after biomarkers to thinking about disease pathogenesis and or biology. And this is a small study that we did in Toronto with Harry and with Adam, which I think really yielded a lot of information. And I'll just highlight, this was a very small study, just 15 patients involved in this study. They started with active disease. They went on TAF. You can see that as expected, the HBV DNA was nicely suppressed, but they had these FNAs done at baseline, at week 12, and at week 24. And then using the FNA samples, we were able to look really carefully at the individual cells in the liver, primarily the immune cell populations, but I'll also show you some virus data. So first was to characterize the CD8 T cell population, which had been shown in previous studies was a major driver of disease pathogenesis. And Shirin Kongolo, who's now back in Germany, in Heidelberg, did this work with Adam, really showing that this autoaggressive CD8 T cell population, you can see that the CD8 T cells really accounted for a high percentage of the total population in the single-cell RNA sequencing, but you can see that panel over at the left has a very distinct profile, these so-called autoaggressive CD8 T cells, which have been described in other types of liver disease and were markedly enriched in the inflamed liver, so at the baseline sample compared to the subsequent treated samples. And importantly, when you looked at this and you compared this to what's happening in the blood, you can see that CD8 T cell population shown at the top and validated with flow cytometry. So you're not just seeing gene expression, but you're also seeing the protein expression, which is important, and that's absent from the blood. So you're not able to see that. You see the same panel of concurrent samples taken from the blood, and you're missing this important population, which is really driving the T cell mediated damage in the liver during active inflammation. And so that's important, that if you rely on the blood, you have the potential to miss this. And a separate or follow-up analysis, what Shirin did was try to understand how these CD8 T cells are generated. This isn't really directly from the liver cells. What she's doing is taking liver donor liver perfusion and then treating these cells with cytokines and seeing if she could generate them. And what she showed is that with different cytokine combinations, particularly IL-2 and IL-12, she could really generate this autoaggressive T cell phenotype where they produce fast ligand, and you can see that if you block fast ligand, that prevents the active killing that's driven by these cells. So this is, again, really a nice example of how you identify a cell population and then show their functional effect from a small FNA sample. Looking at other cell populations, another PhD student in the lab worked on looking at the macrophages in the liver, again from these FNAs, and took samples from different sources, from healthy HB inflamed and cirrhotic livers, and overlaid them. And what you see here is that there's this very discrete population of what he described as inflammatory macrophages that are really enriched in the HBV inflamed liver compared to in the other liver populations where you see other macrophage populations. And if you look at these, you really see that they're really enriched for particularly inflammatory markers, and they're quite distinct from other macrophage populations that are found in the liver. And if you then compare them particularly to macrophages, the embryonic-derived resident macrophages in the liver, you can see that they really look quite distinct. So you see the Kupffer cells in green and these inflammatory macrophages in red, and you can see that for a number of different pathways, these are really distinct cell types. And what he then showed is, again, going back and using that imaging mass cytometry to look at how these inflammatory macrophages, which you can now identify in a liver biopsy sample, interact with other cells. And you see that he stained the IMAX here in green, the Kupffer cells in purple, and then the CD8 T cells. And what you see is when you overlay these, that the inflammatory macrophages are really closely in contact with these CD8 T cells. So suggesting actually a direct interaction, that it's really the macrophages and the CD8 T cells that are driving the inflammation. You can see that the numbers of these cells correlate, and they correlate with the ALT. So this sort of presents a model, and again, this is learnings from one very small trial with just 15 patients included, that really the HBV-specific T cells are not really driving the inflammation and pathogenesis here, but it's really the bystander CD8 T cells that are driving this, that are activated by cytokines, and then in an antigen-independent manner are leading to killing by this autoaggressive CD8 T cell population. And this possibly is driven by these inflammatory macrophages. So you have this reinforcing inflammatory loop where both of them are stimulating each other. Now, the initial trigger for this might be a type 1 interferon that is sensed upon release, which I didn't show these data, but just really highlighting that you can learn a lot from these small samples. And then going beyond the biology of the host, you can actually look at the virus. So this was really, again, using these same samples to see whether you could find the HBV transcripts within the liver. And as shown here, you can indeed find them. And as expected, they're enriched in the hepatocyte and macrophage populations, and they're present at baseline at week 12 and at week 24. And interestingly, if you then look at what you see, you can see that you can now compare infected versus uninfected hepatocytes. And you can see that they actually have different profiles. It's notable that the infected hepatocytes, this is in the setting of inflammation, so some of this may not all be driven by the virus itself, but I think it's an important, again, example of how you can look at and characterize these different cells. And then an interesting observation was that if you use 5' sequencing of the RNA, you can actually identify which transcripts specifically are being expressed in the infected cells. And so you can see what you'd expect to see, the different HBV transcripts, and indeed they're all actually detected in that FNA sample shown at the bottom. And then what's interesting is over time, as you suppress these patients, you treat them with TAF and the virus is suppressed, you see that, as an example here, at baseline, you see high levels of pregenomic RNA transcript is present at baseline, and what you see is that by week 24, that has disappeared, highlighted in pink. And that's actually not really something you would predict that TAF, a direct nucleoside reverse transcriptase inhibitor, would reduce pgRNA transcription. So it's suggesting an effect beyond the known mechanism of action it has on HBV replication. Again, something that you can pick up from this type of study, and in line with other data from using a different approach, a very elegant study done by Ashwin Balagopal from the Hopkins group, really looking at the transcriptional activity within infected cells and looking at the pgRNA and cccDNA to determine this transcriptional index. And what they showed is that, again, over time with long-term nuke treatment, you get a reduction in pgRNA per cell, suggesting that somehow, and I think it's still left to be understood how this is happening, long-term nuke treatment is reducing not just the number of infected cells, but actually the transcriptional activity within a given infected cell, which is an interesting observation, and again, something we would miss if we were not looking in the liver. So finally, how do we think about this with some of the novel agents? And I'm going to give first an example of choosing patients for how we might choose patients for specific therapies. And this is some nice work done by the Gilead group where they biopsied people who were going into that study with tenofovir and peg interferon pre-treatment. They had high DNA and ALT, and at week 96, they were all suppressed. And what you can see is that when they did unsupervised clustering of primarily the lymphoid population, they identified this group you can see in red, this so-called immune high population, and this immune low, the ones in mostly blue. And if you do multiplex immunofluorescence on these liver biopsies, so again, this is not an FNA, this is a full biopsy, what you see these aggregates of T and B cells with macrophages. They almost look like tertiary lymphoid structures where all of these inflammatory cells are coming together around the infected hepatocytes. Now, how does this actually help? Well, they don't really look very different except for the treatment effect. The patients that got treatment had HBV DNA suppressed and ALT normalized. But what you can see is that otherwise they look pretty similar. However, if you look a little bit more carefully, if you start to look at expression of checkpoint inhibitors in these different patient populations, what you see is the immune high population has higher expression of all of the checkpoints, PD-1, PD-L1, CTLA-4, and the patients who are on treatment actually have very low level expression of all of those. And interestingly, they then showed that that correlated with their markers in the serum, the IP10 levels and ICAM1 levels in the serum. So why is this important? Well, we usually think about using checkpoint inhibitors, if you think about where they've been studied, it's been primarily in nuke-suppressed patients, but maybe we've actually been using them in the wrong population, where the expression is high in the PD-1, in this sort of immune-high population, and not in the nuke-treated patients. And so we've seen variable responses, and maybe we've targeted the wrong population. That being said, if we put it into this immune-high population with high expression, we do have to be a bit careful that could lead to very severe hepatitis. But I think it's an important concept of how we could select the right patient for the right therapy by understanding what's going on. And finally, looking at liver tissue with the specific new agents to understand how they're actually working. And so these are data from the INSIGHT study, and I applaud J&J for, even though sort of stepping back from development, have continued to release the data from these really important studies, which give us some important insights into what's going on. So in this study, patients had a core biopsy and a matching FNA done before they were put on an siRNA and a nuke, and then had a subsequent biopsy and FNA at week 40. And so you can see surface antigen decline, and you can see the e antigen and correlated antigen decline on treatment. And then what they did is they looked at these liver biopsies, and then they also looked at a subset of specific hepatocytes from that they pulled out from the FNAs. And so you can see in both the e antigen positive and e antigen negative patients, as you might expect with treatment, you see a reduction in the surface antigen and core antigen staining in both groups. And that's more striking in the e antigen positive group than in the e antigen negative group in terms of the change you see. But then again, looking at what's actually happening in the liver, they're really able to assess where surface antigen is coming from. So they did a nice evaluation of surface antigen from cccDNA, which they interpreted to be in a cell that's HBV RNA positive and surface antigen positive, compared to one that's HBV RNA negative, but still surface antigen positive, suggesting that the pregenomic RNA is not there and the surface antigen is coming off integrated DNA. And what you see here is that the siRNA is active in both groups, and that I think is important, but it also gives us a tool to better understand this question that was brought up in the last session about integrated versus cccDNA as a source of surface antigen. And then to dig a little deeper, you can see what they did here in this one particular patient who cleared surface antigen at week 40. You can see that by staining, the surface antigen is gone and core antigen is also gone in the follow-up samples. But interestingly, what you see is that there are still some cells that contain core antigen and HBV RNA even at the end of treatment. So I think what this study shows us, and I think it's really useful to have these kind of data to confirm the mechanism of action of an siRNA, that it's both targeting cccDNA and integrated DNA, which again we thought was true, but here are data to show it's true, but also suggests that maybe the reason that we have this group of hepatocytes that persist in expressing antigens and may explain this plateau. We don't really know why yet these cells don't take up siRNA, or whether they're truly resistant, that might not be the right word, and that there still is active replication decline, but there's still a percentage of cells that are cccDNA positive, and maybe the slow rebound that you see after the cccDNA, after stopping the drug, may mean that some of that cccDNA is transcriptionally silenced, even if it's still present. So just to show you where liver sampling might have been useful, we are starting to delve into the world of therapeutic vaccines, and this is with the VTP-300 with low-dose nivolumab with different strategies. So you can see the vaccine given as the prime and boost alone, or the prime boost with nivolumab, and sort of mixing in the nivolumab at different stages. And what you see in the bottom are different outcomes. So you see group 1, group 2, and group 3 have different outcomes of their surface antigen decline through treatment. And then if you look at their interferon gamma ELISpot responses from their peripheral blood, you can see that group 2 and 3 seem to have better peripheral responses to the vaccination strategy, but we don't really know. You can see that that doesn't correlate very well with what happened to their surface antigen. Now, it would have been nice to really know what's happening in the liver. I think following up on some of Adam's provocative suggestions about which cells are doing what in the liver would have been helpful to have, and again, just FNAs would be adequate in this type of study to understand what the immune cells are doing in the liver during vaccination. And here's just an example example where it was done, again from J&J, with an siRNA plus the vaccine, and you can see that here by sampling in the liver, you do see that some of the patients who were able to successfully stop their nuke did have a different profile of these polypositive CD4 T cells in the liver, as well as an increased number of mate cells in the liver on the sampling that was done, again with an FNA, and you can see that that was done serially before and then after vaccination. And then finally, just to finish, we have a number of studies that are going on to try to understand these, and these are sort of maturing. The data analysis from this takes a long time, but collaborating with GSK in a multi-center study, the BeFine study is looking at really what's the activity of bepirovirsen inside the liver, and that will be, the data from this will be coming out soon. Similarly with Roche, looking at their PD-L1 LNA, and this has now been completed, and again, to really understand inside the liver what is checkpoint inhibitor therapy doing. And finally, a study that we have ongoing with Vir, looking at their monoclonal antibody in what we've called the VISION study to really understand this vaccinal effect that is supposed to happen with their particular monoclonal antibody by doing the FNAs 3 days after their dosing of the monoclonal. So to summarize, liver sampling provides very useful information, even from a very small number of patients. You can see less than 15 in these trials. Disease pathogenesis, we saw some really interesting data on the interplay between these autoaggressive CD8 T cell population and the inflammatory macrophage population in inflammation. I think we still need to understand what's the sensor and trigger driving these cells to interact and drive inflammation. The therapeutic activity of different agents, particularly I showed you with the siRNA, and then also potentially for patient selection with the example of the checkpoint inhibitors may not be optimal in nuke-suppressed patients. The technology is getting better, and I think you have to be thoughtful about how you choose between FNA and core biopsies. They each have pro and cons, but I would strongly encourage people to be considering doing these studies because a small number of patients with liver sampling can be really informative. And I do want to just thank Adam for, it's been a lot of fun doing these studies together. And in addition to teaching me some immunology, he's taught me how to fish. It's been good collaborating with a lot of the industry sponsors on these studies as either subsets of existing studies or as investigator-initiated parallel studies to ongoing development. And with that, I'll thank you for your time.